It's really a privilege to be a part of a very august panel. I'm looking forward to sharing and updating some of you about our work at Oshner's Biodesign Lab at the intersection of mixed reality, 3D printing, and advanced visualization in healthcare. And what you'll find is a lot of the themes that have come up in these speakers we're gonna re-hit and resonate and harmonize with. First, some formalities, some disclosures not relevant to this talk, as well as some acknowledgement there, support for our research investigations from the Oshner LSU Shreveport CERP program, as well as some philanthropic funding. So going back to a fundamental, you've already heard this, why? You know, that biodesign tenet of what is the need, independent of solutions and technologies, that's driving your process, your operations, and then getting into the what. The advanced visualization, the technology, the solutions. And then we'll talk a little bit about how we're using these tools in healthcare, and then get into the nitty-gritty about what we're doing at Oshner down in New Orleans. And then take a little bit of time to talk about the future, and probably have discussions offline. So this is a video of rotational angiography obtained through routine clinical care. And this is deconstructing what is naturally a 3D object into 2D, which is why this means very little to most of you, and why it takes 10 years of post-collegiate training to get badged and boarded as an expert, and if you guys have your phone handy, you can use that QR code to actually render a 3D on-screen model based on that imaging from the previous slide. And here's a screenshot and a couple of pictures of actually 3D printed physical models. And before we dive into the technologies, indulge me, as a neuroscience nerd, I think it's really important to acknowledge that we are exquisitely and efficiently designed to consume three-dimensional stereoscopic information. That's why this very simian motion, moving it around, is such a powerful information processing gesture. And then let's talk about the technology. Actually, in this room, more and more I get to say that. There's probably people here that can speak much more about this than I can, but AR, VR, and kind of the emerging mixed realities in between and beyond. And then what we don't talk about as much at vMed, but it's really integral and really started, the nerd sirens, if you will, started my journey, is 3D printing, where you can use a variety of methods and materials to add one layer on top of another to produce a three-dimensional object. And as vMed and kind of the speakers can testify, the literature also confirms that there is growing utilization. And there is growing validation, but the literature also says that there is a need to further validate. And so utilization is necessary, but probably not sufficient for validation. But how do we cultivate utilization? And this is where, like Cedars, Oshner is a regional integrated delivery network that is patient-centric. It is a clinical operation first. Research is important, but it's an adjacency. So what does that mean mechanically? For us, when we center that mission in our research, our development, and our operations, we thrive. And through negative learnings, we've realized when we deviate from that, that's when we hit headwinds. And so what does that mean mechanically? We don't use novel imaging modalities, or I don't ask my radiology and radiology tech colleagues to adapt their protocols. We base our models on clinical imaging that is procured through routine clinical care. And those two-dimensional DICOM data sets are then segmented or transformed into 3D data sets by biomedical engineers that are embedded and available to clinicians. And so that allows for clinically informed segmentation, as well as just the opportunity for collaborations between engineers, clinicians, and healthcare-related individuals that has, as you would imagine, it yielded things that are really interesting, and then things that we didn't expect, particularly during the acute period of the pandemic. And then finally, meeting our clinical end users where they are. And I've heard this a lot in my career. You got to meet people where they're at. And I didn't really appreciate what that meant until we went through this process. So we created an EMR record. We use Epic, an order set that allows our clinicians and their staff to order these models in a way that is interdigitated really seamlessly into existing workflows. Asking, including me, a clinician, is press another button, open another app. It's like that scene from Pulp Fiction. Just say what one more time, and you will see someone really, the clinicians, and in this day and age particularly, it drives burnout. And then finally, yes, we use VR, we use 3D printing, and interestingly, more and more holographic displays. But our most fundamental unit of consumption is a simple web-based viewer that allows for 3D visualization as well as some simple manipulation. And because of focusing on that tenet, this figure shows utilization over the last 4 years. Neuroscience, my home field, is in blue. You see abdominal transplant, cardiac congenital surgery, orthopedics, and then you'll see some diminishing. 2020, 2021, because you all probably heard there was this thing called the pandemic, and it really affected New Orleans early and dramatically. And so a lot of these procedures were elective, and or the clinicians, including myself, were redeployed for pandemic relevant needs. But you see in 2022, and this is continued in 2023, is this not just only this rebound, but this growth. Urology, multiple clinicians in urology are now using this with tremendous acceleration. Recently, we've been working with pediatric ENT. And then you see in the neurosciences just a significant volume, the highest utilizers, to the point where that is also differentiating. So our highest volume by far is cerebrovascular disease. Think strokes, think aneurysms, outpouching of blood vessels in the brain and the neck, as well as arteriovenous malformations like the one we just saw in the beginning of the talk. Epilepsy, helping our epilepsy team combine not just anatomical data, but basically electrical or electrical-physiological data to support their procedural decisions to treat medically refractory seizures. And then spine, scoliosis, complex deformities with our pediatric and our adult, for those of you that are in it, and it's really cool to see all these clinicians that are driving this innovation. But orthopedics and neurosurgery also owns spine. And what's not necessarily, a couple of things that are not necessarily intuitive here is, for those of you that have been in healthcare, it's been crazy. There was a contrast shortage, meaning that basically a lot of these images could not be done in about a year ago, 2022, and still you see utilization. And what is interesting is temporal adoption has been inverse to utilization. What I mean by that is CVD is the earliest, most recent adopter. Spine was the first. And there's a lot of insights to be engendered from that. But one of them is that that fundamental question, are these toys or are these tools? I think we've answered is, it's not if, it's just how and when. And like any good question, the answer is it depends. And the difference in utilization, I think, is elucidating the contours of the answer to that question, toy or tool. And I want to give pause and give a shout out to the master's program here run by Brennan when he's wearing one of his many other hats. It has really allowed us, not just me, my team, to have the tools and the mentorship to ruggedize and professionalize our validation and our research investigations. And so this is a graphic basically summarizing my master's thesis, which I'll be back in LA in 2 weeks to present, so I'm not going to give away too much. But one part of the study was just to describe, what are the epidemiological, clinical, anatomical utilization metrics and attributes associated with advanced visualization use in cerebrovascular disease, specifically arteriovenous malformations. On the far left is more of a hypothesis-driven question about, what is the utility of 3D visualization compared to the standard 2D across clinical training levels? And other people have talked about that. Is this as useful for senior staff as it is for medical students? And I'm not going to steal my thunder too much for the master's in health delivery science folks, but there's this concept called February intern, where right around now, an intern that's been in the hospital for 6 or 7 months all of a sudden thinks they know everything. And it only takes a little bit, a lot of training to understand what you don't know that you don't know, the Dunning-Kruger effect. And it's interesting, that was not what I hypothesized, but we're seeing that. And then in the middle, a part of this project is more in its nascency, is using qualitative approaches to kind of really tease out a question that seems to be emerging throughout this panel, like, when and how do we use these different modalities of advanced visualization? And one of the themes that's emerging, I think there may be some healthy debate about this as well, is that digital on-screen 3D models are great for visualization. This simulation, and is it really useful? And this is an infographic we're working with LSU Shreveport Professor Alexander, depicting the creation of these patient-specific physical models. And for me, and probably this crowd, it begs the question: can we combine? Can we add AR visualization on this to really enhance the simulation, like truly mix realities as we speak of? So, and how do we get there? So Ochsner, right now, our biodesign lab has core competencies in two main technologies: 3D printing and medical extended reality. We're using it mostly anatomical modeling, although during the pandemic, we were one of the teams, many across the country, we shifted to very orthogonal space of creating PPE. But right now, mostly anatomical modeling, using it for patient as well as medical education, and then also procedural training and simulation. And there is a future state that seems, not just feasible, but even more and growingly reasonable, where we could use these technologies to design, fabricate, and deploy patient-specific interventions in a co-localized, collaborative way. But how are we going to cross that chasm? And it's not going to be one boat. It's going to be an armada of boats and an army of innovators and disruptors. I think one key vehicle is going to be graduate medical education. What we're seeing, and I think this other speakers have spoken about, is medical trainees, and now growingly, I guess I'm getting older as well, junior staff are not only willing and wanting to use these technologies, but demanding that they have access to these technologies. And another is an old-fashioned traditional physical space. So this lab started out, I'm a community neurologist. I share an office in a community hospital. It doesn't look like Cedars. There was a printer in the corner of that lab. And then we leveled up to a closet, basically, in an adjacent building, and continued to validate and utilize. And then about 2 years ago, in the midst of the pandemic, in parallel with a renovation of the neuroscience outpatient center, we created a physical space that was, again, physically embedded in our clinical operations, our clinical workflows. BMEs were stumbling over neurosurgeons, stumbling over APPs, and we were also, and I thought this was neat that we were able to do this, we were just adjacent to the patient waiting area. So that engendered really interesting interactions and insights, and one of the main ones being is that we need more. So I'm excited to share with you all, probably for the first time, that there's been a transformational philanthropic gift made to the Ochsner Neuroscience Institute. So there will be a new building, multiple new programs and infrastructure to deliver first-in-class neurological care to the Gulf Coast, which may not be as relevant to some of you. But included in this space will be a larger biodesign footprint focused on medical extended reality, where our ecosystem can develop, validate, and I think most importantly, I think a lot of the speakers have talked about this, integrating MXR solutions into healthcare delivery. And like any odyssey, the most important part is your bandmates. Who are you going on tour with? And I'm very lucky to have some amazing lab members, and I think this probably resonates with many of you that are on similar journeys, that it really only takes a synergy of a few to overcome much and many, and that's why I look forward to conversating, discussing, and working with all of you in the next couple of days and beyond, and really appreciate your attention and looking forward to the dialogue. Thank you.
That was incredible. Thank you.